Pleasure to be here this afternoon. What I'd like to do over the next 50 minutes or so is to review for you the antiphospholipid syndrome. And hopefully by the end of the talk, you'll come away with the ability to identify at least what we think are putative pathophysiologic mechanisms of the antiphospholipid syndrome, describe the revised diagnostic criteria for antiphospholipid syndrome and antiphospholipid antibody-associated disorders, also have an understanding of the laboratory tests that we use to diagnose the antiphospholipid syndrome and their prognostic usefulness in patients with systemic lupus and patients without autoimmune diseases. And then also have an understanding and an ability to describe the management of patients with antiphospholipid syndrome. And as an introduction, I wanted to present 5 short clinical scenarios, patient presentations to get the ball rolling here. The first is a 25-year-old patient with systemic lupus erythematosus who presents with an acute ischemic cerebrovascular accident. The second is a healthy 18-year-old woman, a soccer player, who presents with an acute, unprovoked, extensive deep vein thrombosis. The third patient is a 32-year-old woman who now has had her 4th early miscarriage. The fourth patient is a healthy 45-year-old attorney who has significant progressive memory deficits and language defects, and on MRI scanning of his brain is found to have white matter lesions. The fifth patient is also a patient with systemic lupus who is critically ill in the intensive care unit after developing rapid onset renal failure, pulmonary infiltrates, and coma after elective knee surgery. And what all of these patients have in common, what these presentations have in common, is that their disorders might be causally associated with antiphospholipid antibodies. The first 3 patients, the young individual with lupus and an ischemic stroke, the second patient with the extensive deep vein thrombosis, and the third patient with early miscarriage, may have what we call antiphospholipid syndrome if they have the appropriate diagnostic laboratory criteria. Our 45-year-old attorney who has memory deficits and language problems with those white matter lesions on the MRI might have an antiphospholipid-associated cognitive disorder. And then our critically ill patient with lupus who now is doing quite poorly in the intensive care unit after knee surgery might have what we call catastrophic antiphospholipid syndrome. So what is antiphospholipid syndrome? In 1999, an international group got together to define antiphospholipid syndrome based on specific clinical and laboratory criteria. And those served a very important purpose to allow us as clinicians to characterize these patients and in the realm of clinical research to follow them in a systematic way. Those initial criteria, the so-called Sapporo criteria, were revised just last year, and those revised criteria are cited in this issue in Journal of Thrombosis and Hemostasis. And they're somewhat similar to the Sapporo criteria, but with some important differences. As with the Sapporo criteria, the revised criteria require a clinical complication, either a vascular or an obstetric complication. And the vascular complication could be either a venous or an arterial blood clot in any organ or tissue, or histopathologic confirmation of vascular thrombosis without vessel inflammation. And importantly, these patients who have thrombosis in the arterial or venous system could still fulfill criteria for the antiphospholipid syndrome, even if they have coexisting inherited or acquired thrombotic or vascular risk factors. And by that I mean if our patient with deep vein thrombosis has thrombosis while on birth control pills, but is found to fulfill the diagnostic criteria by clinical and laboratory features for antiphospholipid syndrome, that would still be considered antiphospholipid syndrome despite being on birth control pills, a prothrombotic stimulus. Or an individual who has vascular disease, hyperlipidemia, but has a stroke with the appropriate laboratory criteria could also be classified as antiphospholipid syndrome. The second major clinical complications that one of which could fulfill the criteria, are pregnancy complications. So a late fetal demise at greater than 10 weeks without underlying cause, either genetic or maternal cause, a single premature birth of a normal fetus at less than 34 weeks of gestation due to eclampsia, severe preeclampsia, or placental insufficiency. And there are specific criteria mentioned in this paper as to what would qualify as placental insufficiency. They include things such as an abnormal physiologic non-stress test, Doppler abnormalities or ultrasound abnormalities in the placenta, placental thrombosis, and low birth weight of the baby. And then lastly, what one of our case presentations has is recurrent consecutive early miscarriages at less than 10 weeks without identifiable maternal, paternal, or genetic causes. So one of these clinical criteria is required. In addition, laboratory criteria are required, at least one. The presence of a lupus anticoagulant and or the presence of anticardiolipin antibody of either the IgM or IgG isotype at greater than 40 GPL or MPL units or greater than the 99th percentile of the normal range, or anti-beta 2 glycoprotein 1 antibody, again either the IgM or the IgG type at greater than 99th percentile. This last criteria, the anti-beta 2 glycoprotein 1, was not part of the original Sapporo criteria. This is one of the new ones. In addition, a new feature is that these antibodies need to be persistent, but in the old criteria, persistent meant having reproducibly positive antibodies at least 6 weeks apart. The newer criteria require an interval of 12 weeks apart with persistent laboratory abnormalities. So those are antiphospholipid syndrome diagnostic criteria. I alluded to the fact that there are antiphospholipid-associated disorders, and many of these don't fulfill or are not part of the antiphospholipid syndrome criteria. One is depicted here, livido reticularis. This is this mottled erythematous pigmentation, usually of the extremities, which is permanent. It's not a temperature-dependent sort of color change like Raynaud's phenomenon. And histologically, there are microvascular occlusions associated with livido reticularis. That is an aPL-associated feature, but is not part of the APS diagnostic criteria. Nephropathy can also be associated with antiphospholipid antibodies, histologically seen as a thrombotic microangiopathy, but not due to disseminated intravascular coagulation, and not due to thrombotic thrombocytopenic purpura, or hemolytic uremic syndrome or vasculitis. Heart disease and heart valve disorders are also associated with antiphospholipid antibodies. Mitral or aortic valve lesions, or so-called Liebman-Sachs endocarditis. And cardiac microthrombosis on histologic sections could also be an aPL-associated cardiac disorder. Neurologic disease. I presented the case of our middle-aged attorney who was having memory deficits, cognitive disorders. If that individual has antiphospholipid antibodies, that would be a possible aPL-associated disorder. And typically, these are associated with white matter lesions, which I'll highlight for you here. These lesions in the paraventricular white matter are typically associated with this aPL neurologic cognitive deficit. And interestingly, these patients who have this neurologic cognitive deficit often also suffer from the livido skin manifestations. Thrombocytopenia is a feature of systemic lupus, but is also associated with antiphospholipid antibodies, and was part of sort of the traditional triad of antiphospholipid syndromes of vascular thrombosis, thrombocytopenia, and prolonged PTT. The patient that I presented with the catastrophic sort of complications after surgery may have what we call catastrophic antiphospholipid syndrome, a very interesting and often devastating disorder in which there are greater than or equal to 3 organs or systems involved in patients with antiphospholipid antibodies, usually with underlying systemic lupus, and histologically also have small vessel occlusion, and in this case, again, not due to DIC or TTP or any of those other disorders I mentioned earlier. Let's now talk a little bit more about the laboratory evaluation of antiphospholipid syndrome and these antibodies. Originally, the antibodies and lupus anticoagulants were identified as false positive syphilis tests in patients with lupus who also had circulating anticoagulant in their plasma with a prolonged clotting time. Way back in 1952 was this association. About a decade later, it was shown by Bowie and colleagues at the Mayo Clinic that these lupus anticoagulant-associated patients, their plasma could induce in vivo animal models thrombosis, even though in vitro it was acting as an anticoagulant. In 1980, this lupus anticoagulant activity was found to be associated with antibodies against anionic phospholipids. But since that time, we've realized that these antibodies are actually reactive against phospholipid-binding proteins, such as beta-2-glycoprotein 1, prothrombin, or factor II, and others. And that it's a heterogeneous family of antibodies, these lupus anticoagulant and antiphospholipid antibodies. And that it's actually the antigen-antibody complexes that bind to the phospholipids. Again, in general, not the antibodies themselves that bind directly to the anionic phospholipids. There are international criteria in terms of characterizing what are truly lupus anticoagulants and in terms of a laboratory evaluation of lupus anticoagulants. And these are very important for the diagnosis and proper diagnosis of these antibodies. The first step is to recognize that there is prolongation of phospholipid-dependent clotting. It may be seen in the good old activated partial thromboplastin time, but more typically has been evaluated using a snake venom, a dilute Russell Viper venom test, or the kaolin clotting time, or a dilutional variation of the ProTime called the tissue thromboplastin inhibitor assay. What's used commonly here in our community is a variation of the PTT, the so-called StayClot LA assay, which uses a silica-based initiator of clotting, and then uses a phospholipid to prove that it's phospholipid dependent. In addition to showing prolongation of this clotting time, we need to confirm that this is an inhibitor by doing mixing assays with normal plasma. And then comes further confirmation that this activity is phospholipid dependent, and that you can overcome this by adding some form of phospholipid. There's a phospholipid neutralization procedure, or phospholipids derived from platelets. There's a so-called hexagonal phase phospholipid reagent, which again is part of the StayClot LA assay that we use here locally, and other phospholipid reagents. Lastly, we have to make sure that that prolonged clotting time is not due to a specific factor inhibitor, and if it's suspected, you do specific factor assays, dilution assays, to rule out the fact or the possibility of a factor inhibitor. So that's lupus anticoagulant evaluation. How about those anticardiolipin antibodies? Again, the false positive test for syphilis that was recognized over 50 years ago. Well, as I mentioned, we now know that these are antibodies against phospholipid-binding proteins, not directly against anticardiolipin. And it's low affinity monovalent antibodies against beta-2-glycoprotein 1 that in complex now weakly bind to cardiolipin in solution. These antibodies may or may not have lupus anticoagulant activity in the phospholipid-dependent clotting-based assays. And I'll show you some data in terms of how frequently they do so-called cross-react or not. Practically, we use a solid phase immunoassay or an ELISA assay, commonly using cardiolipin-coated plates with the addition of beta-2-glycoprotein from bovine serum for the antibody to bind to. And there are referenced samples for calibration and standardization of the anticardiolipin antibody assay. Anti-beta-2 glycoprotein 1 antibodies are the important ones, the ones that we think about as far as pathogenesis and diagnosis, as we'll talk about. These are a heterogeneous group of antibodies. They can bind to various epitopes, on the beta-2 glycoprotein 1 molecule. Like the anticardiolipin antibodies, may or may not have associated lupus anticoagulant activity. In general, as we'll talk about, they have greater specificity than the anticardiolipin antibodies, at least for antiphospholipid syndrome, and greater positive predictive value for patients with those clinical complications. In rare patients with the antiphospholipid syndrome, the anti-beta-2 glycoprotein antibodies will be the only serologic abnormality that you'll find. And so that was, of course, one of the motivations for the revised criteria to have these as part of the APS diagnostic criteria. Like the anticardiolipin antibody, a solid-phase immunoassay is commonly used, in this case using beta-2 glycoprotein 1 coated plates. And again, there are reference samples available for calibration and standardization with this assay. Prothrombin is also a target for these antiphospholipid antibodies. They can be found directly against prothrombin itself or the complex of prothrombin and phosphatidylserine, an anionic phospholipid. It's the antibodies against factor II phosphatidylserine that seem to be more important clinically. However, we don't use the antiprothrombin presence or absence of antiprothrombin antibodies as part of our diagnostic criteria for antiphospholipid syndrome. But these antibodies that do bind factor II and phosphatidylserine almost always have a lupus anticoagulant activity. The problem is that we still don't know how to use the presence of these antibodies for clinical prediction of antiphospholipid syndrome. This is yet to be defined. Patients who have very active antiprothrombin antibodies, who have such high activity antibodies that leads to clearance of factor II or prothrombin, can have prolongation and sometimes marked prolongation of the prothrombin time, and clinically these patients may have bleeding. This is, of course, in contrast to what we think about in terms of the clinical complications of thrombosis. We see these patients rarely, and they're very challenging patients clinically. We, again, don't consider that these patients fit the diagnostic criteria unless they have a thrombotic disorder. We can identify these patients with a commercially available ELISA. My understanding is that this often is not covered by insurance. But in general, when we have these patients who have this markedly prolonged pro time and clinical bleeding, we see that there is a concordant decrease in factor II activity and antigen, specifically related to these antiphospholipid antibodies or antiprothrombin antibodies. So on a practical level and a clinical level, how do we use these in the clinic, and specifically who gets tested for antiphospholipid antibodies? This is an interesting paper published in Mayo Clinic Proceedings about 3 years or so ago that I think is a nice snapshot of how these antibody assays come to clinical utility. And so they looked at 664 patients who were, whose blood was sent for testing for antiphospholipid antibodies. And they asked the question, who is getting tested and what do these antibodies mean in terms of the clinical questions and clinical disease of these patients. And a little over half of the patients had a suspected thrombophilia referring to a primary hypercoagulable state. About a third of the patients had some reason to suspect a lupus anticoagulant, most likely due to a prolonged PTT. And in a small percentage of these patients, they had a prolonged PTT, but there was concern about bleeding complications. Out of all of these patients, about 20% or so, 137 patients, ended up having a positive antiphospholipid antibody assay, either anticardiolipin or anti-beta-2 glycoprotein 1 or a lupus anticoagulant. And so when they went back and looked at these patients clinically in terms of what went on, this is what they found. And they found that there were 16 patients who had antiphospholipid antibodies who had cancer. And all of those patients who had cancer also had thromboembolism. And this is the breakdown of the different classes of antibodies in those patients with cancer. 38 of the patients who had the positive antibodies had systemic lupus or other autoimmune diseases. And again, this is the breakdown of the different types of antibodies and lupus anticoagulant that they had. 94 of the patients had arterial or venous thromboembolism. And a small minority had lupus anticoagulant only. The majority had anticardiolipin antibodies, with in between having both types of antibodies. And then 19 patients had some obstetric complication, and none of them had the lupus anticoagulant activity. In terms of clinical testing, there are a few caveats. And one is that we find these antiphospholipid antibodies in healthy, normal folks, and sometimes healthy, normal children. The rate of a positive lupus anticoagulant in the general population is 3 to 8%. And if we screened everybody for anticardiolipin antibodies, we'd find it positive in 6 to 9%, and that rate increases with advanced age. Pregnant women also can have anticardiolipin antibodies, lupus anticoagulant activity, with no history of obstetric complications at all. And we know that these antibodies may be commonly formed in reaction to either drugs or some physiologic insult. So reactive or transient antiphospholipid antibodies can be associated with certain drugs, procainamide being one of the more common offenders, phenothiazines and others also reported. Acute viral infections, this is commonly seen in children after a case of chickenpox or other viral infection. They can have transient antiphospholipid antibodies. In the adult population, the infection we commonly see associated with antiphospholipid antibodies is HIV infection. And then we can find it incidentally with other illnesses. These transient reactive antibodies are not, in general, associated with thrombotic complications. There are cases of children with severe chickenpox and then transient antiphospholipid antibodies who have thrombotic syndromes, but in general, these are not associated with thrombosis. And this has been looked at fairly closely in the HIV population and found to not be a thrombogenic risk. So we've talked about the diagnostic criteria. We've talked about the laboratory basis of evaluating these antibodies. How do these antibodies cause disease? What do we know about that? Well, again, as I've mentioned, these are antibodies against phospholipid-binding proteins. And so when we look at these readouts of anticardiolipin antibody and lupus anticoagulant, we realize that these are surrogate markers for the antiphospholipid syndrome. What we now realize, again, is probably at the crux of the matter, at least the major mediator of pathogenesis at this point, is the target of beta-2-glycoprotein 1. We don't know exactly what beta-2-glycoprotein 1 does. It's found in the serum. We do know that it binds to many different phospholipids. It binds to cardiolipin, to phosphatidylserine, but it also binds to thrombin. It also binds to membrane receptors on a variety of cells, endothelial cells, monocytes, platelets, and trophoblasts. And one observation in terms of platelets is that anti-beta-2-glycoprotein 1 antibody, in terms of endothelial cells, can cross-link annexin A2 on endothelial cells, as depicted in this figure from the publication in Blood describing this phenomenon, in that here is the anti-beta-2-glycoprotein antibody bound to beta-2-glycoprotein. It cross-links annexin 2 on endothelial cells, bringing together still unidentified transmembrane adapter proteins that induce intracellular signaling. And in endothelial cells that are stimulated by anti-beta-2-glycoprotein antibodies, we see increased expression of tissue factor and VCAM and other potentially prothrombotic factors. Platelets are also part of the story with anti-beta-2-glycoprotein 1 mediated pathogenesis, or at least we certainly think that they are, as depicted here from the publication describing this association. Here again is the anti-beta-2-glycoprotein 1 antibody bound to beta-2-glycoprotein, which in this case binds to an epitope in the GP1b alpha membrane receptor on platelets. This binding brings together the complex GP1b alpha 9-5 that leads to intracellular protein phosphorylation, MAP kinase activation, expression of thromboxane A2, and presumably other downstream events that lead to platelet activation. Other studies have shown that anti-beta-2-glycoprotein 1 antibodies activate monocytes, increase their expression of tissue factor. These antibodies in vitro systems can inhibit activated protein C complex, activated protein C being one of the important natural anticoagulants. These antibodies can also inhibit tissue factor pathway inhibitor and modulate activated factor 11. and can actually affect the interaction of factor 11 with thrombin. That's part of the nature of the anticoagulant activity for this. But it's also thought that this dysregulation of that interaction has an effect on fibrinolysis, tipping the balance towards decreased fibrinolysis, towards propagating or not lysing a clot. There may be important contributions from other antiphospholipid antibodies, antiprothrombin antibodies that we've mentioned. Again, not part of the diagnostic criteria, but may indeed be there, and may be another reason why the PTT is prolonged, or the phospholipid clotting-based assay is prolonged. But again, in vitro systems, these seem to interfere with activated protein C function. It's not clear how it does that. And they may also impair fibrinolysis, again, tipping the hemostatic balance towards clot formation or impaired clot lysis. Rare patients seem to have anticardiolipin antibodies that don't require beta-2-glycoprotein 1 and antibodies directly against phosphatidylserine. These have been shown in murine models to impair, or I should say, affect the viability and function of murine trophoblasts. And these antibodies have also been shown, again, in a murine model that I'll come back to a little bit later, to perhaps augment the inflammatory activation of complement. And the activation of complement through mechanisms, again, I'll come back to, may affect the viability and function of the placenta. So let's now go back and think about these antibodies within a clinical context. And let's go back to our middle-aged gentleman, or to our 25-year-old patient with lupus who comes in with an ischemic stroke. This is a brain MRI showing, in this case, the ischemic stroke in the cortex, likely due to thromboembolism. And in this 25-year-old patient with lupus, we would certainly be concerned about the relationship with antiphospholipid antibodies, knowing now that antiphospholipid syndrome may present with this type of arterial complication, and therefore we should work up the patient for antiphospholipid syndrome. But once finding those antibodies, how will that affect therapy? So this is a patient with lupus. What do we know about antiphospholipid syndrome and antiphospholipid antibodies in patients with lupus? This paper that came out just earlier this year in the journal Lupus looked at 272 consecutive patients with lupus and assayed all of them for the presence of the antiphospholipid antibodies, and found that among the 272 patients, a little over half had these antibodies. 165 had these antibodies. And they looked at those patients in terms of their thrombotic history, obstetric history, and whether or not they had the antiphospholipid syndrome, and found that about half of those 165 patients did have diagnostic criteria for antiphospholipid syndrome. The other half of those patients with antibodies did not have antiphospholipid syndrome, but were antibody positive. And this is the breakdown in those antibodies to give you a sense of the type of antibodies, at least in a lupus population, that you might find if you screen them and if you find that they have antiphospholipid syndrome. And it's very easy to see that there's a high prevalence of the anticardiolipin type of antibody, with about 50% of patients having the one that we think is probably most associated with pathogenesis, the anti-beta-2-glycoprotein 1 antibodies. And within the non-APS population, only about 10% had the lupus anticoagulant, whereas it was much more prevalent in those patients that had the clinical complications with their antibodies. And interestingly, they followed these patients over the course of 5 years and found that over the course of 5 years, a small percentage of folks extinguished their antibodies, including 3% of those patients with antiphospholipid syndrome lost their antibodies. And is that important? We'll come back and talk about that in terms of long-term treatment decisions. But about 15% of patients without antiphospholipid syndrome lost their antibodies over the course of 5 years. The 5-year follow-up also looked at what happened to patients who had non-APS either with or without antibodies, and whether they acquired new antibodies or whether those patients who didn't have antibodies to begin with developed antiphospholipid antibodies. So over the course of 5 years, among those individuals who had no antibodies at the start, 8 of them developed new antibodies over the course of 5 years. And 4 of those 8, 50%, had a thromboembolic event. So clearly had a complication in the setting of lupus and, again, new antiphospholipid antibodies. Those patients who already had the antiphospholipid antibodies but no antiphospholipid syndrome complications, some of them developed new antibodies. If they had only anticardiolipin, they may have started to develop anti-beta-2 glycoprotein 1. And 3 of those 4 had thrombotic events. Most of those patients were on prophylactic aspirin, the concern being that they're certainly at increased risk of thrombosis carrying these antibodies along with their lupus. So to kind of summarize the story, at least in patients with systemic lupus and antiphospholipid antibodies, as the data I've shown you reinforces, it's common to find anticardiolipin antibodies, less common to find the anti-beta-2 glycoprotein 1, and less frequent the lupus anticoagulant antibodies. Many studies have now shown that if you've got lupus and you have these antibodies and they persist, that about 50% of those patients will eventually develop a thromboembolic event. Importantly, patients with lupus have a hypercoagulable state even independent of the antiphospholipid antibodies. About 20% of patients with lupus who don't have antiphospholipid antibodies also develop thromboembolic events. So there may be some synergy or additive effect in patients with lupus. The data now suggests that the highest positive predictive value for developing thromboembolic events seems to be associated with the anti-beta-2 glycoprotein 1 antibodies, particularly if they're at high titer and if they're associated with lupus anticoagulant. Much more predictive than just the anticardiolipin antibodies. And because of this risk and concern about carrying these antibodies, most patients who have lupus and have the antibodies are given at least prophylaxis with low-dose aspirin. Let's now turn to our young woman, 18-year-old soccer player who presented with the unprovoked left lower extremity deep vein thrombosis, which, as you can tell here, a very extensive deep vein thrombosis affecting that leg. Here, too, as we talked about, if this woman has antiphospholipid antibodies, she would fulfill criteria for antiphospholipid syndrome. But in a healthy young woman who doesn't have lupus, and particularly who has an unprovoked thrombosis, an idiopathic thrombosis, what other things do we need to think about in terms of thrombogenic risk factors, acquired or genetic risk factors? And this is where we hematologists come into play. We see many of these patients. In general, we think about thromboembolism, venous thromboembolism, or VTE, being the end result of often multiple risk factors. In this case, it may be acquired antiphospholipid antibodies, but they may be associated with genetic or inherited hypercoagulable states, or thrombophilia. There may be environmental or situational risk factors, sitting on a plane for 10 hours, or just having surgery and being immobilized. Or there may be other risk factors such as birth control pills or pregnancy. They may, again, be additive in resulting in a venous thromboembolic event. And we think about what precipitated the initial event in terms of how we think about risks of recurrence, and I'll show you data on that in a minute. And the risk of recurrence also, whether what precipitated that first event is still there or not, or whether that is now gone. The woman has stopped her birth control pills, the baby is delivered, or whether there's an inherited risk factor that's there for the lifetime of the patient. And so we also need to think that venous thromboembolism, after you've declared yourself with an event, is a chronic disorder. So just briefly to review the genetic thrombophilias, because again, that's important for us to think about in this young woman with an unprovoked thrombosis. There are disorders that are associated with mutations in specific factor coding regions or non-coding regions. One that's the most common hereditary hypercoagulable state, so-called factor V Leiden mutation, interferes with the ability of activated protein C to neutralize active factor V and active factor VIII. Another fairly common hereditary risk factor is a mutation in the 5' untranslated region of the factor II gene that leads to increased levels of factor II and increased risk of thrombosis. There are so-called loss of function mutations that affect the proteins involved in the natural anticoagulants. Protein C deficiency is due to mutations in the protein C gene. Deficiency of protein S, which is the cofactor with protein C in the activated protein C complex. And then deficiency of antithrombin, the other quite important natural anticoagulant, leading to, again, tipping of the balance of forming clot and preventing clot formation. There are abnormalities that affect the levels of procoagulants. We've already alluded to elevated factor II here. There are patients that have unexplained persistent elevation of factor VIII coagulant activity that we see as a risk for initial thrombosis and probably recurrent thrombosis, but that's somewhat debatable. And other factors is listed here. And then there are disorders of methionine metabolism leading to elevated homocysteine. Patients who are rare patients who are born with abnormalities affecting fibrinogen and dysfibrinogenemia, leading to formation of fibrin, which is very resistant to lysis, and so therefore a prothrombotic risk factor. So we think about these genetic disorders in the context of an 18-year-old woman who all of a sudden has a large venous thrombosis and what that woman might be carrying as hereditary or acquired risk factors. And this is somewhat of a complicated slide, but it's to drive home the point that we now have enough clinical data from a number of cohort studies that are abbreviated up here on the top that give us a sense of if you have one of these hereditary disorders, what's your relative risk of having that first thrombotic event? And so relative risk is on the y-axis, and listed below are these hereditary disorders that I just reviewed for you. And the different colors of the bars relate to the different cohorts that are being studied. And I don't have time to go into the various different cohorts, but you can see that it varies based on which abnormality you have. And if you have a combination of abnormalities, or if you have homozygosity for a mutation in factor V or a mutation in factor II, the relative risk is quite high. At this end is the relative risk if you have antiphospholipid antibodies or the lupus anticoagulant either alone or with antiphospholipid antibodies, again from various studies. So significantly high risk, much more, at least from most studies, than at least the common hereditary disorders as listed here. So when we have an 18-year-old woman who has an unprovoked large deep venous thrombosis, we feel compelled to do thrombophilia testing. But there is some debate about thrombophilia testing based on what you're going to do with that information, and it's very expensive. So we always are very thoughtful about should we test and should we not test. And a rationale and justification for testing, I think, should be based on the fact that if you find something, if you find one of these genetic disorders or antiphospholipid antibodies, it will affect how you treat that patient and mostly affect how long you would likely treat that patient with anticoagulation, and or that information may well be important for family counseling if it's a hereditary disorder. We also need to take into consideration the psychological and emotional impact and certainly be excellent counselors in terms of transmitting information to the patient and family regarding what they have and what it means. I've listed here what I think and many experts think is a reasonable approach to doing thrombophilia testing, including antiphospholipid antibody testing. And in a young individual who has an unprovoked thromboembolic event, particularly if they have a family history, I think it's worthwhile to screen for all of these familial disorders as abbreviated here. Yes, we'll spend $1,000, $1,200 in doing this, but in this high-risk situation, particularly with family counseling implications, I certainly think that it's justified. In older individuals who have an unprovoked event, or in a younger individual who has a provoked event, let's say the woman was on birth control pills, particularly if there's a family history, a more limited, cost-effective screening, I think, is still reasonable. And of course, within both groups is looking for those antiphospholipid antibodies as the most important acquired thrombophilic disorder. And if you screen a young individual with an unprovoked or idiopathic first venous thromboembolic event with that $1,000 workup, what might you find? Well, you'll find antiphospholipid antibodies or lupus anticoagulant in about 10% of those individuals. But the most common thing that you'll find is this factor V Leiden mutation, activated protein C resistance. You'll also find a fair number of patients with factor II mutation or elevation and persistent unexplained elevation in factor VIII. And then there'll be a group of individuals where you'll spend all of that money and really think that you'll find something and not find something, just indicating to us that these individuals who, for no good reason, have venous thromboembolism, there are still undefined abnormalities that tip the coagulation balance towards thrombosis. So I've told you about antiphospholipid antibodies in lupus patients. How about in, let's say, this 18-year-old woman who doesn't have lupus but may have the antiphospholipid antibodies and antiphospholipid syndrome? This is the distribution of the antibodies that you're likely to find. And as you'll notice, it's a little bit different in terms of a higher percentage of patients who don't have lupus but have thrombosis will have these anti-beta 2 glycoprotein 1 antibodies with or without the lupus anticoagulant. And so in general, the studies in non-lupus patients have shown that the most sensitive way to detect antiphospholipid syndrome, still we look for the anticardiolipin antibodies. IgG is much more relevant than IgM, and particularly at high titers as defined by the criteria, and particularly if it's associated with lupus anticoagulant. But really the more sensitive and specific assay is related to finding anti-beta 2 glycoprotein 1, and especially if there's associated lupus anticoagulant. Sensitivities and specificities in the range of 50 to 90% here. Lupus anticoagulant alone, sensitivity specificities in the range of 50 to 80%. Anticardiolipin antibodies really more in the range of 20 to 40% or so. Just briefly, there's a little bit of data on children with antiphospholipid syndrome. It's rare, but it occasionally does happen. These kids can have deep vein thrombosis or strokes, and there's about equal reports of both. Interestingly, these kids often go on to have other problems. They can have CNS disorders related to seizures or chorea. They often frequently have lupus anticoagulant and anti-beta 2 glycoprotein 1 antibodies, and commonly these kids are found to have hereditary thrombophilia, probably not surprisingly. And also not surprisingly, the girls with antiphospholipid syndrome not uncommonly go on to develop lupus. In terms of anticoagulation, another important thing we think about is if you have antiphospholipid antibodies or hereditary thrombophilia, what's your chance of recurrence and how long should we continue anticoagulation? The take-home message here is that if you have antiphospholipid antibodies, your risk of a recurrent thrombosis after you finish your course of anticoagulation is much higher than if you have one of these hereditary disorders, and even if you have combined hereditary disorders. So very high risk of recurrence if you stop anticoagulation with persistent antiphospholipid antibodies. So in terms of treatment recommendations for thromboembolic events, we treat acute arterial or venous events with usually intravenous heparin or low molecular weight heparin followed by warfarin. There's a bit of a caveat if your initial event is just an ischemic stroke or a TIA, and we'll come back to that in a minute. One caveat is that if you use unfractionated heparin to anticoagulate, we follow unfractionated heparin by using the APTT assay, but that may be prolonged because of the lupus anticoagulant. So you need to either use a heparin activity assay or a lupus-insensitive reagent to follow the PTT. Because of that high risk of recurrence that I just showed you, in general, we consider that patients should stay on indefinite warfarin after their thrombotic event with persistent antiphospholipid antibodies. And the range of INR we use for pro-time monitoring of warfarin usually is in the range of 2 to 3. Some experts would say if you have an arterial event, particularly a bad arterial event, we might use a higher range of anticoagulation, but that's controversial. I mentioned that if your patient has an initial ischemic stroke or TIA, we might not use anticoagulation. And this is based on data from the APS study and other retrospective studies where it was found that particularly in older age individuals with antiphospholipid antibodies that aspirin alone seemed to control the rate of recurrence just as well as warfarin and just as well actually as nothing, at least in subpopulations. So aspirin alone in an older individual may be okay. The caveats with these studies is that they did not actually do the rigorous diagnosis for antiphospholipid syndrome criteria. So I think it needs to be a case-by-case judgment whether you use aspirin or not. Sometimes your patients recur on warfarin, and if that happens, you have to give higher dose warfarin or you add aspirin to the warfarin, or you switch to a heparin to prevent recurrence. And that can happen in about 10% of cases. And this has been driven home by actually data derived here at the university through the Anticoagulation Clinic and published by Ann Witkowski, where it was shown that patients with antiphospholipid syndrome who have ongoing adequate anticoagulation have about a 10% per year recurrence rate compared to patients, the control group, that had no antiphospholipid syndrome. Patients with antiphospholipid syndrome often have other complications that require hospitalization or ER visits. Bleeding rate, happily, is still low with carefully regulated anticoagulation. Let's now move on and mention the patient with early trimester miscarriage, the woman that had the 4th trimester miscarriage with early fetus implanted in the uterus here. Among these women who have recurrent miscarriages, about 10 to 20% will have antiphospholipid antibodies. And not only are they at risk of recurrent miscarriages, but these women have a significantly increased risk of thromboembolism, even if they've never had a DVT before. So we have to be thoughtful about that. Why do antiphospholipid antibodies cause this? There's evidence that these antibodies may impair the effective placentation. They may cause thrombosis in the placenta. And something I mentioned earlier is complement-mediated injury. And this is illustrated on this recent review that shows antiphospholipid antibodies activating complement with C5a binding to receptors on platelets, monocytes, or neutrophils, leading to their activation, elaboration of cytokines that then cause inflammation and tissue damage to trophoblasts and placenta. Heparins are a good way to block this. This has been shown in animal models. And in fact, this whole system has been shown to be active in a murine model of antiphospholipid syndrome. So in terms of this information and in obstetric complications, how do we manage these patients? So patients who are found to have a prolonged PTT and antiphospholipid antibodies but have never had an obstetric complication, in general, we would consider that those women are at risk, so we have them on prophylactic aspirin. And because they're at risk of thromboembolism, we have them on prophylaxis in the postpartum period where the risk of thrombosis is quite high. In a patient who's already had obstetric complications but no prior thromboembolism, we'd have that woman on not only aspirin but low molecular weight heparin during pregnancy to try to get her through to a successful outcome. If that woman has had not only pregnancy complications but has also had a prior thromboembolism, we would also combine aspirin with low molecular weight heparin. But if the woman is on chronic anticoagulation, we would have her on therapeutic doses of low molecular weight heparin rather than preventative doses. And those patients who have had prior thromboembolism with their antiphospholipid syndrome but no miscarriages, we again have them on aspirin and low molecular weight heparin. So as a hematologist, we understand this algorithm. We often work closely with our colleagues in high-risk obstetrics to manage these women. And there are nice algorithms there in the published literature showing you this one as an example that help us think about these women, even though they may be complicated in terms of their risks and so forth, when to think about aspirin, when to think about anticoagulants, and at which stage of pregnancy. To finish up with here, let me come back to our gentleman, the attorney with progressive memory deficits, language deficits, white matter lesions, and our patient who's now critically ill, who has lupus and developed these multi-system failures after knee surgery. Our 45-year-old, again, has an antiphospholipid-associated neurologic disorder. These are patients that have typically these white matter lesions, so definite CNS deficits. But it's not due to thrombosis. It's not due to arterial or venous clots. The pathogenesis is unclear. It's presumed to be microvessel thrombi, but it's just not clear. And the pathogenesis, again, is not clear. These are somewhat rare individuals, and so we don't have any data on how to prevent this or even how to treat it once we recognize it. So there's no good data or evidence to guide us in terms of this 45-year-old attorney, whether he should be on anticoagulation or aspirin. And in some cases, these patients are treated like lupus patients. Even though they don't have lupus, they might get cyclophosphamide or other immune modulating agents because this can be a devastating complication. That individual in the ICU after surgery, the individual had lupus, now has what we would call catastrophic antiphospholipid syndrome. This can be quite devastating and is, again, a multi-system disorder and associated with antiphospholipid antibodies. Interestingly, it's triggered by surgery, can be triggered by infections, but can lead to, again, multi-system failure. Pathogenesis is unknown. Again, histology shows microvessel thrombi, but it's not due to DIC, not due to TTP, thought to be related to the antibodies. These patients are usually treated very aggressively. If they're not bleeding, we anticoagulate them. We give them high-dose corticosteroids. And we often think about either intravenous immunoglobulin or therapeutic plasma exchange. And in some cases, add Cytoxan. Luckily, this is rare, but something that when you see it, again, you need to think about it and act quickly and treat very aggressively. Lastly, we've talked a lot about anticoagulation. We've talked about some immunomodulatory approaches in patients with lupus. There are a few other things in the literature in treating antiphospholipid syndrome that you may have encountered, or if you're a rheumatologist, you may have used. One is hydroxychloroquine, an agent that has anti-inflammatory properties, can affect endothelial and platelet activation. In mouse models of antiphospholipid syndrome, hydroxychloroquine seems to limit thrombus extension. And there is some evidence from conflicting studies in patients that the level of antiphospholipid antibody production may be affected by hydroxychloroquine. But randomized clinical trials are not available, so the jury is still out as far as hydroxychloroquine, Plaquenil in this setting. Statins also have been found to be effective, again, in a mouse model of antiphospholipid antibodies. Statins have anti-inflammatory and activities down-modulating platelet endothelial cell activation. Here again, we just don't have guidance in patients to guide us in terms of using statins in treating antiphospholipid syndrome. And then lastly, in patients that have severe antiphospholipid syndrome, Cytoxan or other agents, systemic lupus types of therapies have been used. We have actually done autologous transplants on rare patients with severe antiphospholipid syndrome, recurrent thrombosis, autologous stem cell transplant in hopes of eliminating the autoreactive clone, engrafting with an immune system that doesn't have that autoreactive clone. So to summarize our discussion, antiphospholipid antibodies are found not that uncommonly and often incidentally in normal individuals. They're usually transient, maybe related to infections, but often are harmless. Persistent antiphospholipid antibodies, particularly in patients with systemic lupus or those with obstetric complications, are important. And in those individuals, they increase the risk of venous and arterial thromboembolism. Persistent antiphospholipid antibodies can be associated with idiopathic venous and arterial thromboembolism. I concentrated mostly on patients with venous thromboembolism, but again, something we think about in patients with unexplained arterial stroke or other peripheral arterial events. And anti-beta-2 glycoprotein 1 seems to be the major mediator of the pathophysiology and pathogenesis of antiphospholipid syndrome. The diagnosis is defined by those clinical criteria and relates to having both clinical criteria, either a thromboembolic event or obstetric complication, and persistent laboratory abnormalities. We reviewed the therapy of patients with either the thromboembolic complications or women that have the obstetric complications with antiphospholipid antibodies. And these therapies do work. They certainly do prevent the risk of recurrence of thromboembolism and do result in women having successful pregnancy outcomes. Certainly there is a cost of bleeding, and at least in Ann Witkowski's experience here, about a 3% per year risk of bleeding in the thromboembolism population. And this is an area ripe for research and discovery. I think we have these mouse models, but there's a lot to learn still about antiphospholipid syndrome in the area of pathogenesis, certainly a lot to learn, I think, in the area of prophylaxis and therapy for our patients with these disorders. Thank you very much.